Hello, everyone. Rob Azure and Dr. Naren Rajan here to talk about solving some 3D problems in scanning for dentures on the lower arch, the mandibular arch. You know, the mandibular can be troublesome and problematic with really any iOS scanner. It's not a specific problem with a particular scanner. It's more just a problem with using an intraoral scanner, scanning the lower arch and getting a full extension of the border and the sulcus, and sometimes the case or the scan data can be compromised. So Dr. Naren is with us to talk about the problems or the limitations in scanning a lower arch, and sometimes you have some analog tools in your toolbox that can actually do a better job of capturing the data on the lower. And instead of abandoning the workflow, we're just going to step out of a digital workflow and then come right back into that workflow to really optimize the case for the patient. So, Dr. Naren, thank you for being with us. Let's dive into scanning a lower arch and some of the limitations of that, and the tools in your toolbox that you use to solve some of those problems with an analog step, but not abandoning the digital workflow. So, walk us through that.
Yeah, thanks a lot, Rob. Thank you for having me on. And I think this is an important topic because when I first digitized, probably like a lot of doctors, when you get an intraoral scanner, you say, okay, I don't really need my impression material anymore, and I can basically use my scanner. And the fact of the matter is, for the majority of cases, you can, but you are going to come up with clinical situations throughout the day. You do certain kinds of cases and say, hey, it's really not that easy to scan this case. And I'm having problems stitching. Maybe the patient has a lot of bone loss, or they're overactive soft tissues, or their salivary glands are very active. And these are all things that I found as I started to use the scanner. And so the example today is that a patient comes in and they're partially dentulous, and you're trying to make them a partial. Maybe bilateral distal extension or unilateral, and how do we really leverage the scanner for it? And so what I found is that it's easy to use the scanner for what it's good at, which is picking up non-movable structures in the mouth. So tooth structure, keratinized tissue, but most scanners start to struggle once you're in the mucosa, once you have movable tissue, because when the scanner goes in there and it's trying to stitch images, and the buccal mucosa is changing or the tongue is moving, it starts to get a little bit confused. And although the scanners are better now than they were 10 years ago when I started, it's still not always predictable. And so there's a couple of techniques that I'll do to be able to really leverage the advantage of a digital bite scan, and leverage the scanner for all that it is working with, but also just sort of combining it with some analog techniques that are not that difficult, and you combine them together and you get the best of both worlds.
Yeah, it's that idea of using an analog tool to step out of a digital workflow, capture some good data, and then going right back into the digital workflow and finishing the case, and taking full advantage of the accuracy of 3D scanning, but also the benefit of using a physical impression. So why don't you walk us through a case
Sure.
That you've done recently, and how you did that, and how you captured the original bite scan, the intraoral bite scan, and the importance of that, and then highlight how you use that to align the scan of the lower from the impression to the original scan.
So one of the example cases that I was going to show, that I'd like to show today, is a case where a patient is coming in, and the patient's going to need immediate dentures for the upper and the lower arch. In this particular case, it was because the patient was going to get full arch implant treatment for both arches, but this case can be handled exactly the same way if the patient was just simply going with a removable option. So a patient that presents like this with a lot of pathologies, there are multiple missing teeth, there's a collapsed vertical dimension, there's severe wear, and so trying to figure out how to start a case like this, in the analog workflow would really involve taking 2 alginate impressions, and then trying to take some kind of a bite registration. Maybe even needed to make a wax rim and have the patient back to be able to get a proper bite. Maybe opening the bite, which can maybe happen in the mouth when you take your records, or you do it on an articulator after you have the case mounted. But in this case, we're trying to do as many digital inputs as possible. So this is just a basic upper and lower scan with a bite on the left and a bite on the right. And so if I was going to use these scans for an immediate, I may use it for the upper, and I know that the border is going to be somewhat short, and I'm willing to accept that because it's very easy to reline an immediate denture. But on the lower, you can see on the right side, I am going to have a short border there as well. And in this case, we're going to use it as a prosthesis that we're going to convert to some implants that are going to be made. So on the day of surgery, these teeth are going to come out. The bone is going to be reduced. And then I have very few landmarks to basically place this denture back in. So I really do want the borders in this case. And if you were doing a conventional case, maybe there was no implants, I think we can all agree that maybe we would want a little bit more border extension. Or maybe a better way to say it is, if I took a physical impression, would my borders be better or worse than this? Probably they would be better.
Yeah.
And so in this case, we actually opened the vertical in the patient's mouth using a leaf gauge. So we seated the condyles, we used a leaf gauge. We wanted about 3 millimeters of opening. That's a somewhat arbitrary amount at this point of the case, but we ended up basically using that open bite record to then design a digital denture that was milled, and that denture was fit, and it was converted on the day of surgery, and we came back to the lower arch there. So we kind of phased this case over about a month, and so we basically just built up those lowers. The patient acclimated to the upper arch, and now it's time for me to do the same thing on the lower arch, and I decided I did want more border extension. So how do I use the bite relationship that I have here, except have a better recording of the lower arches? So I know that I want to maybe take an impression here, but how do I get that to come back into this bite? Because if you just simply take an alginate of the lower and you pour a cast, now how do you mount that back? You would maybe have to go back to analog. Maybe you have to get a bite rim, or you use a blue mousse. But the way that we develop these cases, it's very simple in your office. Just go ahead and take that alginate. You have a good border extension. It may even be slightly overextended, but that's okay. And the way that we actually cross mount this is we go back into our scanning software, and this file, we're going to basically just copy it. And so when we copy it, we have an exact copy. We have the upper, we have the bite that goes on the left, the bite that goes on the right, and we have the original lower. And so all I'm going to do is I'm going to delete that lower in the copied order. So now in the copied order, I still have the upper scan. I have the bite on the left, the bite on the right, the bite relationships that we know that we want to transfer into the software. And if I delete this lower scan, now I have my model in the office. I'm going to use my intraoral scanner, and in the scanning window where I just deleted that lower scan, I simply scan the stone cast. Now, when I hit the next button, and we're in the 3Shape world here, when I click next, it's going to want me to align the bite. Now, what I still have is the bite scan that was originally related to that lower scan. Now that I don't have that lower scan, I still have this bite. So in the next screen, I'm going to basically just do a manual alignment of this lower stone cast that was just scanned in. It replaced the original. And I'm just going to pick my 2-point alignment, and now I can cross mount my stone cast to my original records there. And so now when I go to the computer screen, when I get into my my lab software, I have everything that I need now, and I have better border extensions. And now when I design a denture based on those records, I have a much better time on the day of surgery to be able to seat that denture, to be able to make sure that it's aligned properly when I do my conversion, or if the patient was just using this as an immediate denture, it's going to be a lot more accurate when I do my reline, and I'm not trying to make up a lot of the structures and the borders because it was super short. And so this technique can be used for lots of different cases. And so that's actually one way to sort of do it. And maybe we'll come out and we can kind of talk about this before I go to the next one. Did you have any questions about that, Rob? You think that's clear to the viewer?
The simple brilliance is the obvious point of an intraoral bite scan of the natural dentition in the mouth, the upper and lower related together. And that bite scan is what you called the gold scan that you preserve, and it's accurate, and then you're using it to map and sort of digitally mount the scan of the new lower arch. Talk me through why you choose to pour a stone model and scan a stone model instead of scanning an impression, right? Maybe someone could argue, well, isn't it better to scan an impression instead of scanning a copy of an impression?
That's a great question, and that's actually something that we're working through in our school right now as we're digitizing this part of the curriculum for our dental students at Toro College, because they said, why do we even need stone? Let's just scan the impression, then we throw it away, and that's a great way to do it. There's two challenges in a dental office, though. If you scan that patient and they have kind of lower anteriors, maybe the patient has bone loss in the back, when you take that alginate and you want to scan the underside of it, you're going to record the posterior sections very well because it's not too deep. You can get the borders, right. You can get the top of the keratinized tissue, but as you get to the natural teeth that are remaining, you have really tall teeth in some ways, and then it kind of exceeds the scanning depth of the scanner, and so sometimes it's hard to actually get the scanner in there and get it to actually see the incisal edges of the remaining teeth. That's one issue. And so when you pour a model, now you can just scan it like you're scanning in the mouth, and it's much easier to do it that way. The other problem is that once you scan the intaglio, you need a way to actually flip that. You're taking a negative and you need to make it into a positive, and that can be done, but not in the scanning software, or at least in the one that we're actually using. So that would involve now exporting out your negative into some kind of a CAD software and flipping the normals. You can do that in Mesh Mixer. You can do it in the lab softwares, and then you'd have to to come out of the scanning software, go into some other software, flip it, bring it back in, and import it. And although you did avoid stone, you just created these other steps. And are those other steps, does that make your life easier or harder when you're working through the day? So if you simply just have a little bit of alginate, a little bit of stone, maybe even fast-setting stone, you can stay within the scanning software. You're not going to have a problem scanning thin lower anteriors and struggling with it. You're also not going to have this issue of flipping a negative to a positive. You're staying in the positive side of things, like you're treating a patient through the whole workflow. And so those are things I just kind of learned on the job to try to figure out, hey, it's okay to have a little bit of stone. It's okay to have a little bit of alginate, but let's digitize everything as early in the process as we can so that when we get to a computer screen to design the teeth, we have all of the records in high quality.
Yeah. So your use of stone is purposeful, right? And I think that's the key point, is that you understand what you're doing, why you're doing it. So yes, we're going to pour stone and we're going to scan stone, and the benefit is we're scanning a positive record. And also, if you have long teeth, you don't have to worry about the scanner capturing those teeth and that capturing the focal depth of a cavity inside of an impression.
Exactly.
So it's an obvious point now that we talk about it, but I'm sure there are doctors to be tempted to, I gotta scan the impression because it's better. It's like, well, in this case, pouring up a quick alginate might actually save you some time, be easier, and be a great workflow.
Yeah, so I found that to be super helpful, and so I kind of think of these workflows as kind of in pathways, so that when I have a patient that comes like this, I say, okay, I'm probably going to do a cross mount in this, and I'll stay digital that way. The other case that we talked about, the one I'm going to show you, is another way to do a distal extension, leveraging the digital bite scan, but not doing this cross mounting and actually not taking a full impression and not using a stone cast. So I'll show you that one. So this is a case I'll show you that I treated several years ago. And if you looked at this patient coming in, needs a partial denture, a distal extension on the right side. Patient's had a lot of bone loss. There's open embrasures everywhere. And if you think about treating this case analog and taking a physical impression, if you use an improgum, good luck. You have to make sure that you've blocked out all of those embrasures with wax, because if you get it caught in there, especially if it's advanced perio, you may take a tooth out, and that's probably happened to all dentists at some point. It's not something that you want to happen a second time, and so it's stressful. It's also not 100% accurate, because once you block all those areas, if your wax ends up moving into some of the areas of contour where they need to survey in a class for a partial, it's not 100% accurate. The impression material also has to tear out, which can sometimes impact the quality of the model. So from that standpoint, I would love to use my scanner so that I don't have to worry about all of those challenges with managing the open embrasures at the gingival aspect. But when I use my scanner and I'm going to try to get into this patient's vestibular areas on the lower right, I may have some challenges. It may be tough. And the reason I know that is because I tried to do that on this patient, and his tongue was moving, a small mouth, and so then I was like, if I could just take an impression, I wouldn't have to worry about that. We could just put some periphery wax, I could get an alginate, and I could really record the distal extensions. And so those are the pros and cons to using one technique over the other, but we can actually just use both of them. So in this case, what I did was I started with a trio scan. So I just scanned, starting from the second molar. I could bridge across the dentulous area in the lower anterior pretty easily. And then I just basically did a straight scan up the edge, all the way up to the retromolar pad on the right side, knowing that I didn't really get any border extension on the buccal or the lingual, and I'm not really worried about it at this point. So I sent this to the laboratory, and I took an upper scan, and I took both of my bite scans. So they're coming in, and they have the correct bite. Then they basically just use the printed model to make my framework. They're able to mount the case in the lab, and they're able to do a wax try-in. So at the next visit, I haven't taken an impression. All I've done is taken a scan at this point. I basically have a wax try-in with my framework. And so at the next visit, I'm trying in the framework. And these frameworks fit really well as long as you do a proper scan path. We know that a scan is accurate cross-arch down to 50 microns, maybe even more now. And we were all taught in dental school that you could take an alginate to do a partial denture case. And we know that an alginate can have a cross-arch variation of 160, 170 microns. And if we accept that partial dentures work with that amount of error, we know that it's going to work really well with 50 microns. And that's why these frameworks fit like a glove. So let's get back to the other issue. Now I have a framework, I have a try-in, it looks good, but I still don't have the distal extensions. If we had the lab simply process this case now, we're going to have really short borders that then we're going to have to manage. So
this case we're looking on is up to this point is made from the intraoral scan.
All digital so far.
So far.
And I could finish it, but I may have a compromised outcome with the flanges on the right side. So how can I now basically do something to record the part that I didn't really get well, with the scanner?
So it's like almost like you want to add additional border extension data to this case so that you're able to extend the borders, but also utilize the benefit of the cross-arch intraoral scanning for the fit of your partial.
And the fact that I'm going to record something manual and not have to worry about having the impression material go all the way to the other side and get caught into the undercuts, and that's where a lot of the headaches happen. So in this case, I went back and I kind of fished out an old technique that maybe every dentist learned about when we were in school. Was not the most fun thing to do in school. I kind of dreaded this. The altered cast technique is a really old kind of technique where you basically split the cast. You take an impression of your vestibules at the framework try-in stage, and we go back and we basically cut the cast, re-pour it, and this is originally meant to relate the soft tissues to the hard tissues on your framework there. And so we basically just do that now. And so at this case, so I have my framework. This is all digital at this point. I've tried it in. The bite is good. The fit is good. So I basically take it out of the mouth, paint the distal extension with some adhesive, and I just use a putty. This is a Dentsply product called Quix Putty. And so I'm taking a very simple guided impression. It's segmental. And now I have those extensions really, really nice. I have border molded out on the buccal there. I send this back to the lab, and they basically split the cast. And so this is literally a split cast, half printed, half stone. And so now they can process the case with the proper border extensions. You can even see, you can see some of the muscle attachments there. And so now when I try in this partial at the end and I give it to the patient, I have all of the boxes checked. I have good framework fit, I have perfect occlusion, that all came from the scan, and I have really good borders, because had I just processed it from the scan itself, that part would have been short. So this is just a different way of handling a clinical situation that may come up.
What I love about that case is the clasps and the metal framework was built upon the accuracy of an intraoral scan.
Exactly.
But then your border extensions were built on the benefit of a border molded impression with your altered cast technique, which is
very easy for the patient. It's not an unpleasant thing to have a little bit of putty in there, and it was in there for maybe 45 seconds or a minute or so. It's a fast setting, so easy stuff.
That's really, really cool. Really, really cool. So thank you so much for spending some time with us. Just really quick, how many years have you been on your 3D dental journey? And, where are you at today?
Yeah, I'm finishing 21 years in practice, and basically 17 of them have been digital in some way, shape, or form, from same-day CAD CAM back then all the way up to kind of full digital today, between scanning. I do most of my own lab software design, 3D printing, prototyping, and it's really just amazing to be at a point where you have all these tools to be able to leverage and make treatment so efficient and predictable and comfortable to the patient, and that usually ends up meaning more profit for our practice.
Yeah, and I just love your confidence in working with 3D scanning, 3D workflow, but then also having that holistic mind around some of the traditional analog processes, and where you might need to step out of the workflow to leverage some benefit over here with an analog impression, but then stepping back into the digital workflow and utilizing it all together. So
yeah.
Thank you for.
So I hope this helps. Doctors that are just getting started, and maybe you kind of have some head scratching moments, when you're with a patient. So hopefully this will give you some tools to think about.
Awesome. Yeah, Dr. Naren, and you'll be available at rebel3d.com/Naren. That's /Naren. You can book time with Dr. Naren. He'd be happy to spend time with you one-on-one to talk about your scanning, talk about your clinical workflows, and solving some of those pesky 3D problems. For many of us that have some gray hair in life, it's because we've had some case failures, or cases take far too many patient appointments, and we've learned a few things. And Dr. Naren, I'm sure you've learned many problems to avoid over the years, and so the simplicity of your workflows today are a result of many years in practice. And
I would never go back. I would never go back to doing things the way that we used to. And we want to try to help everybody else get there too.
Awesome. All right. Well, thanks for your time.